Good afternoon, everyone. Today I'm going to talk about a case of bilateral orbital granulocytic sarcoma in a child. This 10-year-old Syrian boy came to us referred from another clinic for both eye affected. The right eye started to have this painless subconjunctival mass resembling the salmon patch in one eye, preceded by left rapid axial proptosis in a period of only 1 month. Initially, at that time of the examination, the vision was normal and all the examination is normal, no history of trauma, no constitutional symptoms. This is the extraocular muscle movement. So he had limitation of elevation and adduction with diplopia in primary position. MRI from the referring hospital showing intraorbital mass infiltrating the extraocular muscle, and they gave the provisional diagnosis of orbital pseudotumor versus lymphoma. We repeated a CT scan later showed there is an increasing in the mass with the starting of the compression of the left optic nerve. So the provisional diagnosis by the radiologist at that time showed rhabdomyosarcoma. During this time, and due to the delay of presentation and delay in the referral, the patient lost his vision in the left eye with NLP vision and relative afferent pupillary defect. And after the meeting of ophthalmologists with the pediatric oncologist team, they reached the diagnosis of lymphoma versus rhabdomyosarcoma. The patient had to take biopsy, CSF analysis, and bone marrow biopsy. However, because we didn't have an oculoplasty surgeon on call at that time, they started with the CSF analysis and the bone marrow biopsy. 2 times it became negative. So the specialist on call at that time didn't have any option but to take an incisional biopsy from the right conjunctival mass, which shows gray tan soft tissue tumor, which is a brown blue cell tumor matching for myeloid granulocytic sarcoma chloroma. So the patient received 3 sessions of antibiotic, and currently he's taking the 4th session. Improvement was noticed immediately after the 2nd session. The conjunctival mass resolved completely, and the left eye regained back to its normal position, but the vision remained poor. Repeated MRI showed regression of the mass, but there is still remaining tumor inside the globe. So, chloroma is a rare tumor in pediatric age group. It's a form of extramedullary leukemia in patients with acute myeloid leukemia. This type of tumor can present initially without the first presentation as a leukemia. So, they can present either in the orbit, bone marrow, CSF, or anything. And that's what makes the diagnosis very challenging. So the disease often presents bilaterally, and one literature review said that leukemia is the most likely diagnosis when there is bilateral involvement of the orbit. Acute myeloid leukemia in this child or any child with granulocytic sarcoma will present eventually in a period of year or more. So the differential diagnosis, as we said...
Your time is up, I'm sorry.
Okay. So we will go to the question. My question actually for the expert, what is the role of early versus late surgical debulking in such case? And now after the 3rd session of chemotherapy and there is evidence of remaining intraconal mass, is there any rule of debulking, exentration, and was the incisional biopsy the best option to do in such case or not?
Okay, great. Thank you very much.
Okay. You want to come first? Okay, can I? I think that this is a very interesting case. There are several reports in literature, and still, I recently reviewed the literature about that, and because I face a couple of cases of that. And things that there is, it's a good question, your first question, because apparently, particularly for those cases that as onset as isolated lesion in the orbit without evidence of general leukemia. The thing is that they can develop leukemia afterwards in the coming 2 years. So the question is if it's better to just debulking of the lesion. I would not suggest exentration. There is no rule for exentration, but the bulk of the lesion probably might have a rule with local irrigation of chemo or even only steroids, and not delivery chemotherapy from the beginning. Although there is a case report series shows that if you apply the protocol for leukemia from the beginning, the chances to have a late development of general leukemia are less. But it's short case serious, of course.
Yeah, I mean, in my mind, I consider these patients to have leukemia, and so I think they're treated that way. You know, with regards to exoneration, I don't think there's any role for that unless there is going to be some improvement in their chance for survival. And so I would not disfigure this patient just to control the tumor locally, especially if they have systemic disease later.
Okay, what about the incisional biopsy done by the specialist at that time? Would that carry out a risk of spreading of the tumor?
I don't believe so. I think that it's already out. I mean, I think that it's
Yeah.
there's already the potential that it's going to be a systemic disease.
Okay, thank you. Thank you.